Flash press.
You can pray for us, sir.
Father, we pray for you for this today. We thank you for the strength. We thank you for the motivation you've given us. We thank you for helping us thus far. We commit ourselves to you that you will guide us in our study. We ask that you give us understanding, you give us speed so that we get the best within the time allotted. Because in the sense of the will. Thank you, Lord. In Jesus' name, we pray.
Amen. So so you answer fast so that we can get to the next question. What is the increase? Which of the following is an established risk factor for breast cancer?
Obesity,
Age, number one.
obesity is increasing age.
No, obesity is only increase in postmenopause.
Postmenopause.
You're sleeping yesterday. Sorry. I don't know whether I sleep or whether somebody called your attention. I think something like that. Okay. Which inherited genetic mutation is not typically associated with increased breast cancer risk?
APC, that's colon cancer.
Yes, other ones that are associated are BRCA1, P10, P53, CDH1, STK11, CHEK2. Which of the following breast condition does not increase risk of breast cancer?
All right, let's continue. Hello?
Yes.
Sorry. Okay, let's continue. Which number now?
Number 3, non-proliferative
Which
cyst.
of them? Okay, yeah, non-progressive cystic disease.
Number 4, what reproductive factor is associated with increased risk of breast cancer?
Early okay.
Yes, late menopause, nulliparity, delayed fresh pregnancy.
Increased estrogen exposure, that's
Yes,
the
estrogen.
reason.
What mammographic feature is strong independent risk factor for breast cancer? Are you with me, sir?
Danny, just hold on. I'm having some doubts. I'll come in 2 minutes. I want to attend to you. Just 2 minutes.
Okay.
Okay. Number.
Okay.
Hello, Jonas.
Yeah. This is number
We are
5.
number 5. Which
Yeah, which mammographic feature is a strong independent risk factor for breast cancer?
hybrid density?
Yes, how many fold increase?
5. So,
5-fold increase, which is actually more than the 2 to 3-fold increase associated with what? It's actually higher than the 2 to 3-fold increase in breast cancer associated with what? First degree breast cancer. Which combination?
Associated with.
First degree relative, the risk of increase.
Okay. Yeah.
Which combination acts synergistically to increase breast cancer risk?
High breast density and nulliparity.
High breast density and nulliparity. They will act together to increase.
Nulliparity.
So somebody is nulliparous and have high breast density. Number 7, which hormonal or lifestyle factor modestly increases breast cancer risk?
Mm-hmm.
Combined hormone replacement therapy. Combined hormone replacement therapy, oral contraceptive,
Yeah, yeah.
postmenopausal toxicity,
So that's
alcohol use modestly increase the risk. Then, unfortunately, even combined hormone therapy is increasing the risk. That's sad. But it doesn't increase the risk. I think it doesn't increase the risk for endometrial cancer, but it does for breast cancer, which are the following decreases breast cancer risk. Number 8,
see, gamma
with tamoxifen. Tamoxifen and selective estrogen receptor.
protection with tamoxifen.
Tamoxifen,
Gamma protection.
yeah,
Gamma.
lower breast cancer risk. Tamoxifen and SIMS, selective estrogen receptor modulators. They lower the risk. Which geographic region is associated with a lower incidence of breast cancer? Ish. Asia and Africa. Are you there, sir? Hello.
Asia and Africa.
I couldn't hear you, sorry. What about
Asia and Africa. I noted from Asia and Africa.
which reproductive factor is protective against breast cancer?
High
Hyper,
parity.
yes, and early first pregnancy. How does obesity affect breast cancer risk in premenopausal women?
Decreases slightly.
Yes, modest decrease. Postmenopausal obesity increases the risk. Which lifestyle factor is associated with
Unlike menopausal. Postmenopausal.
yes? Which life factor is associated with post with those related breast cancer risk?
Alcohol consumption.
The more the dose, the more the cancer risk. Which of the following statements is true regarding BRCA mutations?
How to follow is true regarding breast consultation. Breast consultation. C.
There are high penetrance breast cancer genes. Um, BRCA mutation, only
What
BRCA1.
does that imply? Their dominant gene.
It means that, penetrance means that how many percent of people will develop the cancer if they get this gene. Some genes, even though they can cause cancer, maybe 10% will develop the cancer out of those that have the genes. But high penetrance means that, the chances of developing cancer is very high. That's why they look bilateral prophylactic mastectomy. Prophylactic bilateral mastectomy. Um, so that's it. So what is the effect of physical activity on breast cancer?
Decrease risk moderately.
It moderately decrease the risk of breast cancer. Which group of medication is associated with reduced breast cancer,
Selective sodium receptor modulators.
like SIMS, tamoxifen, and the rest? Go. Next. Following statement regarding mammographic density are true, except I give us 90 to answer this question.
So, come out. I'll say D. D.
Yeah, okay.
D.
Yeah, D. I'm trying to select mine too. Let me see. I'll go with D too.
Is okay. Oh, is B. The two B are the most expensive testosterone they share with.
While mammographic density is one of the strongest risk factors for breast cancer overall. It is not limited to specifically associated with only estrogen receptor positive tumors. Yeah. It decreases the risk of both ER positive and ER negative breast cancer. The statement focusing only on ER positive tumors is an overstatement and thus false. Oh, is well. Actually, D is also, I didn't want to, D was actually somehow because D, old women have less density in their breasts. Okay. So, but as well, let's pick it since it's the one that has the most, so, so let me quickly review the points here and then we'll be done. This one shouldn't take much time since it's not a very difficult entity. Let's come here. Just a comment. Let me open up the new page here. So, what is from breast cancer supplements? Okay. Expand and explain for pathological purposes. Okay. What is mammographic density? Is defined as to be a fat white portion of the breast of mammogram. It reflects fibroglandular tissue, epithelium plus stroma versus fatty tissue. Fatty tissue is less dense. Fat is radiolucent, dark. Connective and epithelial tissues of the dense, white. The same mammographic density is what the percentage of breast area that appears dense in mammography. Why does mammographic density matter? It's a strong, independent predictor of breast cancer risk. Women with densest breasts are those between 75% density. And these women have 4 to 6 times higher risk of breast cancer compared to women with the least dense breasts. Breast density accounts for 60% of all breast cancers. Density can mask tumors on mammogram, leading to interval cancers, that is, those diagnosed between routine screenings. Age-related and hormonal changes. Normally, density is highest in the younger women, and it can increase even up to the third or fourth decades of life, then begins to progressively decline. Multiple pregnancies accelerate the decline of breast density. Menopause also accelerates the decline of breast density. Hormonal factors like estrogen can even increase the density of someone's breast. Other factors that genetically affect breast density is like age, parity, menopause. This is explain only 20 to 30% of variation. But there's some studies that have shown that breast density, demographic breast density is inherited. If a woman has a very, very dense breasts, her offspring have higher chances of having dense breasts as well. Then in radiology, there's what we call the BI-RADS classification of breast density. There's score 1 to 4 of breast density. BI-RADS is a classification that wants to look for chances of tumor. Anything less than 25% glandular is almost entirely fat. Then we have score 2, which is scattered fibroglandular densities, around 25 to 50%. Then those who have more than 50% to 75%, we call those ones heterogeneously dense. Then you now come to the extremely dense. which are those looking at 75% glandular. Bioreacts is essential for radiologists and has implications for follow-up recommendations. When it comes to cancer risk and subtypes, denser breasts have increased risk of estrogen receptor positive tumors. But most data do not consistently support strong associations between density and hormone receptor or molecular phenotypes. On the surface, if you look at it, it appears as the denser breast will give you estrogen receptor positive tumors. But studies do not validate it. Studies show that it doesn't really matter if it's positive or it's negative. Yeah, but breast density increases the risk of breast cancer. And you have to be cautious here. Association is very certain, it's not certain as cause. Because
Fat is black.
sir,
Okay, I'm listening.
there's a difference between association and causation. Many things are associated with breast cancer, but not with direct cause. Factors that can
Yeah,
compound
yeah.
these things include lifestyle. One may be drinking a lot of alcohol, using estrogen pills, genetics, maybe breast, the basic metabolic index, BMI, obesity can confound all these relationships. The mnemonic is just dense breast means dense risk plus difficult detection. I think we are done for now. We have done most of these already. So let's see.
Let me look at that BRAT again. But after we finish even everything. Catalingulodermatous electron. Okay.
I'll call it breast fat supplement. Breast pathology supplements. Implemented learning. Yeah. Okay. Okay. Let's go down to okay. Let's quickly review questions here. No. Let me keep from here and give the questions. So what mammographic component appears dark or lucent to mammogram?
In fact,
What percentage what is percent mammographic density?
percent of the glands, radio dense.
White areas. What is
Mm.
the relative breast cancer risk in women with densest breast compared to those with least dense breast?
Okay. So 4 to 6.
4 to 6 fold increase compared to men with fatty breasts. What does breast density typically, how does it change with age?
It decreases with age.
Especially after pregnancy and menopause. Which hormonal factors can alter mammographic density?
Hormones.
Natural hormones, medications. Approximately what percentage of mammographic density variation is explained by age, parity, and menopausal status?
20 to 30.
What have twin studies shown about mammographic density?
20.
It's inheritable quantitative traits. So if a girl has a twin and she has dense breast, most likely her other twin will have dense breast also.
It is heritable. Both of them are likely to have.
Yeah,
It is heritable.
yeah. What is the viral classification system used for?
Density.
Breast imaging reporting and
And
data systems, virals. There's five breast density on mammograms. Which viral category
which
describes uh,
one entirely fat is one.
what percentage of general tissue defines virals for?
Greater than 75%.
What describes startile fibroglandular density?
Para two.
I still to, like 25 to 3% startile fibroglandular. Which one describes represent heterogeneously dense tissue?
3.
Which factor has the strongest influence on percent mammographic density?
Increased density.
Yeah.
Sorry. Stronger influence on person genetics.
No.
Mhm.
What effect do pregnancy and menopause have on breast density?
Decrease.
Why is high breast density clinically important besides being a cancer risk factor?
This the ability to detect tumors on mammography.
Failed breast cancer and mammography. Thank you. Next question. I need 75 seconds. This is 90 seconds for this.
Okay. Okay. So
Oh, this audio's answer.
I'll say
Yeah, go.
hey,
Okay, eight. So what tumor is this?
it's like a basic carcinoma with micropapillary features. Um, or maybe invasive, maybe micropapillary. Cut or say within clear spaces with semi-lymphatic channel inside that pattern. The five polarity. Cut or cells within clear spaces inside that.
If invasive micropapillary carcinoma. Is it a kind of breast cancer?
Is a variant.
Let's look at the CAP protocol and see if it's one of the variants there.
They have tendency for Lymphovascular inflammation.
The next one for what?
Lymphovascular inflammation.
Okay. Microinvasive carcinoma. Invasive carcinoma of no special type, or called ductal carcinoma. Microinvasive carcinoma. Invasive carcinoma with mixed ductal and lobular features. Let's see. Invasive micropapillary carcinoma. Is it now? It's invasive micropapillary carcinoma.
Okay. Third question.
So this invasive micropapillary carcinoma. We're going to look at pictures of it also here.
It's also found in the bladder. That is incorrect.
Eh?
I said this type of cancer is seen in the bladder too.
Yes, in many places.
Okay, there is a bladder, commonly lung, ovary, salivary, and colon. Okay, so when you maybe if you have some metastasis to somewhere, you might need to do
Breast markers.
immuno breast markers, maybe bladder markers, and all that
Mm,
to rule out which one.
yes. Give me a few minutes. Let me get to this book. So clarifying the correct, so let's see. This is false because micropapillary pattern of invasive breast cancer has been described in many organs, not just the breast. It is seen in carcinomas of the urinary bladder, carcinomas of the lung, carcinomas of the ovary, carcinomas of the salivary gland, and colon, among others. Where it similarly carries an advanced prognostic implication. Key features of invasive micropapillary carcinoma. We'll look at some key features of invasive micropapillary carcinoma. Number one, classic micropapillary architecture, small tight clusters or modular-like groups of tumor cells floating within clear retraction spaces resembling lymphatic channels. Perfect. Look at this. This is small tight clusters or modular. What is modular? You know this, huh?
Developing embryo now.
Hmm?
Developing embryo.
Mm. Yes. Well, what is a morula-like structure? What does morula mean actually?
I know Morula is like all those developing
Yes,
empire.
you can find picture of morula. Morula. Morula is a solid ball of cells resulting from division of your fertilized ovum, you're right, from which blastula is formed. So if you have something like this is zygote, blastula, gastrulation, gastrulation is when you form three joint layer. This is a blastula hollow ball, zygote, state cleavage. Then where's the morula itself? Let me see. Morula is just a ball of cells. I see. Oh, with a symphony. Let's let it begin. It's morula. Morula now forms cystic spaces, gastrula. Blastula, from blastula to gastrula. So, when we come here, we will say classically that. So you have morula-like group of cells floating within clear refracted spaces that look like lymphatic sand channels. Let's look at more examples. Perfect example. Perfect example. Perfect. This one even looks papillary. If I say micropapillary, but this one looks purely papillary self. Micropapillary. If I say papillary carcinoma, this one if I say papillary carcinoma. There's invasive, is there invasive papillary? There's invasive micropapillary. Is there anything like there's intraductal papillary adenocarcinoma with invasion? Are you aware?
Into what?
There's an entity called intraductal papillary adenocarcinoma with invasion. So there's invasive papillary, there's invasive micropapillary, something like that. So this one is solid papillary carcinoma of the breast. There's solid papillary. There's so many solid papillary. Let me see. Solid papillary carcinoma with invasion. You're just showing me a different kind of tumors. So these are not what we're looking for. This one is encapsulated papillary carcinoma. It's another entity too. Let's see which is there. Encapsulated papillary carcinoma with invasion. So how many we have encapsulated papillary carcinoma with invasion. We have solid papillary carcinoma with invasion. We have intraductal papillary carcinoma with invasion. What is called invasive papillary. So what is the hallmark of invasive micropapillary carcinoma then? What is the hallmark of invasive micropapillary?
Micropapillary structures within clear spaces.
Yeah, like morula-like growth of cells within clear spaces. If you say papillary, like this one is not invasive papillary carcinoma.
Papillary carcinoma have true fibrovascular core.
Yes. This is invasive papillary carcinoma of the breast. We have solid papillary carcinoma of the breast, solid cells that have some papillary features. Then we have encapsulated papillary carcinoma, where there's a strong capsule surrounding it and then papillary structures inside. Just come back here. So inside out pattern. They also have what we call inside out pattern, where the apical luminal surfaces face outwards toward the stroma instead of inward toward the glandular lumen. That doesn't make sense to me. On electron microscopy, microvilli are found on the external cell surfaces. The apical lumen surface faces outward toward the stroma. Important pitfall. Those retracted spaces, are they lymphovascular spaces?
Yes, they are lymphovascular spaces.
No, they are called retraction artifact. They are not lymphovascular spaces.
Okay.
It's an important pitfall. However, these tumors often have true lymphatic invasion too. Yes, they can have
Okay. They have tendency for lymphovascular invasion actually.
yes, but these spaces where they find themselves, they're not lined with endothelial cells, so these are not true lymphatic spaces.
Okay. Okay.
The immunoprofile. What kind of tumor is it going to be?
Estrogen positive, PR positive.
And HER2 neo positive. Compared with invasive breast carcinoma of no special type or previously called reversible ductal carcinoma. So proliferation markers include cyclin D1 expression, increased Ki67, frequent MyC amplifications. So what are the proliferation markers for this tumor?
Majority detail. Ki67,
Yes,
cyclin D1, and MyC amplification.
MyC amplifications, yes. Um, what are the what is the IHC profile? What is the IHC profile? Are you there? Hello? 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 Hello, sir, are you there?
Yeah, I'm there. I said, can you hear me?
I couldn't hear you. What's happening?
Okay. Clinical cyclin D1 expression, incubation rate, medicine.
I'm saying is that what is the IHC profile for this tumor?
You have breast cancer, breast positive, breast marker positive, ER, PR, R2
It's
positivity. Then you
triple,
go have some other breast.
it's triple positive.
Yeah, that's what I can see here.
It's triple.
Then some other breast markers too are positive now. GATA3, mama globulin,
Those are,
GCD.
you don't need to know all those things. I think you need to know the most important ones. I don't know, Sha.
Mhm.
Those things are
The
so.
only neat thing is that you just need to know them if you want to know the origin, for instance. It's not limited. Is this from the lung? Is this from the breast? In case you have a metastasis somewhere, or you don't know the origin of a micropapillary tumor.
Yeah, yeah. So
Uh-huh.
what I would say is this, is that this tumor is actually. So we should know these ones. So these ones, the proliferation markers, the cyclin D1, KS7, frequent MyC amplification is necessary. The triple positive, then it's a triple positive breast cancer. That's important for now. There are ones that you don't when you start practicing, you're not going to be doing all these catatria, kind of thing. You know the most basic things for management. Those ones when you have questions, like you say, when there's metastasis, you want to prove or something like that. Clinical behavior and prognosis. What is the rate of lymph node metastasis in this invasive micropapillary carcinoma? Is it high or low?
Is I
Why? Because it has high, strong propensity for lymphovascular invasion, you understand, and nodal metastasis, even when the invasive component is small or focal. Have you come across this tumor before?
I don't remember.
Why did you know it had a very high tendency for LVI,
For
for lymphovascular invasion?
I read it now.
Okay. The rate of nodal metastasis is higher than no special type carcinoma of similar size. So it has very high propensity for LVI, even with a small focus and metastasize. Prognosis. In the variant analysis, what's the prognosis? Good, bad, worse.
Was prognosis because of that risk of mutation. Never was plan mutation and later
And
metastasis.
the metastasis. Even the impact is less clear after adjusting for nodal status and other factors. The differential diagnosis will include mucinous carcinoma, but what is the hallmark for mucinous carcinoma?
Greater than, but you to make that diagnosis, you must have greater than 90%. of the tumor exhibit that uh, architecture for you to make the diagnosis.
And then
Then,
what?
then marker for mucin is positive.
You have to have greater than 50% of extracellular mucin in the tumor. They just use 50%. Then we have carcinoma with mucinous features. For you to call something mucinous carcinoma, extracellular mucin must accompany 50% of the tumor. Let me see. Let me see something. I'm trying to see this inside out pattern. What does it mean? No, these tumors look like triangle. The apical pattern faces outward toward the stroma instead of toward the glandular lumen. Like here, look at it inside out. So the inside of the tumor faces out. If you look at this apical pattern faces out, not in the lumen. Let me see if I can get. I don't know what that means. Anyway, it lies the inside out pattern. So miscellaneous carcinoma has to be greater than 50% of mucin. Intracellular mucin accompany the tumor. Ovarian carcinoma metastasis of the breast can also be CIS. Comparative genomic hybridization, CGH. What is the molecular finding in this case?
Mm, I'm not sure what it is, but just I'm going to find it. Compared generally means IMPC. What's IMPC?
Invasive
Personality.
micropapillary carcinoma. Sometimes
Okay.
it's not no special type tumors.
Okay. Closer to pure
Yes.
than to classic. Yeah.
Biomolecular genetics is very similar to the tumor of no special type in terms of CGH testing. I'm not sure what that means, but let's quickly review our questions and
You don't need to know it.
so what?
Okay, next thing, Gavin.
Okay. Give me a few minutes. I'll be back shortly. Sorry, let me use myself. Okay, the first statements about MMPC is true.
Inside outgrowth pattern.
Can you explain that?
Well, the line itself that made up the tumor, instead of the facing the lumen, you're facing stroma. But that's the explanation.
Okay. Let's look at let's yeah, I want to explore this in a little bit more. Let's look at explain in detail.
With picture illustration. With picture illustration.
With pictures. Big pictures. It doesn't make sense to just memorize it. Normally, epithelial cells have their apical luminal surface inside the lumen and the basal surface anchored at the basement membrane. In IMPCs, practice reverse. Apical surfaces face outward toward the surrounding stroma. Basal surfaces are oriented inward. So let's see. So look at what is the apical surface of the cell? I understand now. There's reverse polarity. I think the apical surface has more abundant cytoplasm.
Hmm?
The apical surfaces have more abundant cytoplasm.
Okay.
Without the nuclei will stay at the base. So we see that here, you see the apical surface that has microvilli facing outward, while the nuclei still at the base. So the base, normally the base, when you look at this here, so this normal cells, nuclei will be at the base, what will be here, facing inward. But here you see the abundant cytoplasm up. You see the nuclei at the base, the surrounding nuclei are at the base, the apical surface are the one facing outside. Let's see.
Okay.
Now it's inside out.
And they are more abundant cytoplasm.
Now, I think the apical surface normally usually have the abundant cytoplasm. Normally the cell will sit, the nucleus will sit at the base. You understand?
Yeah.
This one doesn't follow what I said. But this one I see the nuclei sitting outside. Let me see. I want to be sure. We have a good illustration. So in histologic appearance, tumor cells form tight mural structure without fibroscope skull. We don't take it in good faith and continue because of time. Okay. Question number 2. What feature in AMPC leads to inside-out description?
Typical microvilli facing the stroma.
Typical microvilli facing the stroma.
Okay, so they have more abundant cytoplasm, right?
Towards the surface, that's what I think. You understand? This inverted carcinoma is seen with areas, small clusters with retraction at the surface around them with reverse polarity of the cells. Do you understand what I mean by reverse polarity? A cell,
Yeah, yeah.
good.
Mm.
Which statement about the metastatic behavior of IMPC is correct?
See, even small focal IMPC lesion have the high metastasis rates.
Initially lymphotropic. Which receptor profile is typically seen in IMPC?
Triple positive, ER positive,
The triple, but
The ER often
the only triple positive tumor I've seen so far.
and often, but it's like ER and PR possibility is common.
Okay. What histologic mimic must be considered in the differential diagnosis of AMPC?
Metastatic colorectal carcinoma.
The micropapillary features can mimic IMPC.
Hmm.
What features help distinguish mucinous carcinoma from IMPC? Hmm?
More abundant nursing.
More than 50% of the tumor area and a
Yeah.
large inside outgrowth. What cytogenetic feature has been noted in IMPC? What are the proliferation markers?
IMIC,
Mm-hmm.
cycle D1, PI67.
Yeah. IMIC amplifications and high D1 expression. Which organ beside the breast have reported micropapillary carcinoma patterns?
Long bladder, every colon.
Colon, ovary, bladder, colon, ovary, bladder, and lungs. What molecular analysis showed mixed IMPC and NST? Which one?
Comparative genomic hybridization.
PGH. Comparative genomic hybridization can show that there's mixed IMPC and this that clusters together. So, what is the clinical significance of micropapillary pattern urivate analysis?
What is the significance for worse prognosis?
Yes.
Because
What
of that invasion, vascular invasion, and other metastasis.
what is univariate versus multivariate analysis? What does it mean?
I know it's a science. I don't know the detail, but I know it's a statistical methodology. Maybe it can show association or causation, but you can check.
I think univariate is comparing one to one or something like that. Univariate is when researchers look at one factor at a time. Okay. To see how it relates to a patient's outcome. So when we look at the macropapillary pattern without focusing, adjusting for other factors such as lymph motility, macropapillary is linked to worse outcome. Multivariate is when researchers adjust for factors such as tumor size, grade, lymph node status. Macropapillary pattern doesn't always independently predict worse outcome. This means that other factors might explain much of the risk too, because it's very prone to metastasis and all that. Which feature is not characteristic of IMPC? Low nodal metastasis rate. Are you there?
Yeah, yes.
You're not responding, so that's what I called. What morphological mark defines IMPC under light microscopy?
See small cluster of cells in clear retraction spaces.
Which receptor pattern often differentiates IMPC from metastatic ovarian cancer?
ER PR with R2 positivity and introductory carcinoma component.
No, introduction is not argues against it. What common molecular marker is overexpressed in NPC?
Second one, mycin.
What is true about HER2 in INPC?
D.
Yeah, okay. Next question.
Increase risk of lung cancer.
What's the answer?
I said DHL.
I say HER2. When did you last see this, all these tumors? All these things? When did you last see it? See them?
Hmm?
When did you see this last?
See them that there was a time I studied for FRC part one.
Okay.
Mm. So I came across all these things.
Wow. Where last did we see this FTK11, P10, CDH1, T53? We saw so recently. Where was that? Remember? What tumor was that? What was that?
Mm. It's already like this Jaggers to syndrome.
Yeah, this is breast cancer risk. Oh, tumors associated with breast cancer. ATM, check two. BRCM, BRCA1, P10, P53, CDH1, CSTK11, check two, ATM. We are right. It's VHL.
I like to.
Sir?
Okay.
Besides VHL. So, check two is not even here. Check two and ATM. I don't know that. So, what is VHL tumors associated with?
So I didn't get what you say.
What is VHL associated with?
For then the power syndrome.
Remember, von Hippel-Lindau disease, von Hippel-Lindau tumor suppressor gene. What are the diseases associated with tumor?
Kidney. Huh?
Clear cells here, clear cell renal carcinoma. What else? Pheochromocytoma. What else? Hemangioblastomas of CNS and retina. What else? Pancreatic neuroendocrine tumors. What else? Endolymphatic sac tumors. Okay. So tumors that can associated with breast cancer, BRCA1, BRCA2. Name all the tumor suppressor genes associated with all the genes associated with breast cancer. Inclusive of breast cancer.
STK1,
Okay.
10, CDH1, TP53, BRCA1, BRCA1, BRCA2.
Yeah. ATM check two, TB53. Okay. P10. Okay. Well, quickly.
Which syndrome is ATM associated with?
Ataxia-telangiectasia, something like that. So one of the lymphatic something, but it's also actually with breast cancer. Yeah. Let's review quickly and then we'll answer questions and then we'll go to the next question. I think this is good. Okay, we still have 20 minutes. So let's review quickly. So, let's see if we can so CDH1, let's get them. So let's get it. So TB53 is associated with what syndrome? Sir?
Leaf-Ramirez syndrome
Deformity syndrome. What kind of gene is TB53?
is what?
What kind of gene is it?
Is tumor suppressor gene.
Yeah, the tumor suppressor gene. Very good. What's the meaning, please? So, sorry. Hmm. What's the mode of inheritance of TB53? Mode of inheritance.
Is autosomal dominant.
Good. What are the cancers associated with it?
Maybe eye penetrance or what?
Cancers associated with TB53.
Okay, breast cancer, sarcoma, brain, adrenocortical leukemia.
What is the mechanism of action?
What is it?
Mechanism of action.
Loss of cell cycle checkpoints control and defective apoptosis.
Mhm. CDH1. What is associated with what disease is associated with?
Lobular cancer of the breast, familial diffuse gastric cancer.
What does the
And
gene what does it encode for?
it encodes E-cardiarin,
Yeah.
which is an addition
Mhm.
molecule.
What mode of inheritance?
Okay, is autosomal dominant.
What is the lifetime risk of breast cancer, breast carcinoma in patients with CDH1?
Sorry, breast cancer, 50%.
Yes. What is the pathogenesis of CDH1?
Is loss of E-cardiarin, which disrupts cell addition, promotes discohesive growth, and carcinogenesis.
Okay. P10 is associated with what syndrome?
Cowden syndrome.
What is Cowden syndrome?
You have, I think it's actually familiar adenosis colon, another instance. Colon cancer, endometrial cancer, thyroid cancer, amatomatous, mucocutaneous hamartomas,
Yeah.
trichomonas. Have you done dermatopathology?
We have lectures. Yeah, we do is that I'm not a rotation there, but we have lectures once every Friday.
You have lecture every Friday?
Then pass lecture.
Eh?
Yes, we have lectures every Friday on them part. But we are
On on
dermat
different pathology system.
on dermatopathology alone.
Do you have another system too?
We have daily lectures on all the systems.
Wow. Who give the lectures?
The attendings now.
Oh, consultant give lectures. Give like students.
Hmm? Eh? What is
So
it?
they give lecture to you like students.
Yes. In fact, this afternoon, this morning, we had a lecture on bone and soft tissue from a Harvard lecturer on Zoom. This afternoon, we have one of the experienced people giving lecture on GI. I did join. Don't do that. Need any of the Zooms. In Nigeria, they don't give lectures.
And they give, but it's not like regular. You understand? It's just that when you have slight discussion sessions, then they now teach using those slides. But or you also have what we call like
Unknown side.
black stars, like unknown.
Those
You
ones are
do that too.
we have special unknown sessions for different systems.
Mm,
Like GY pathologists will come, GYN pathology can give unknowns on GYN. Cytology give unknowns on cytology. You have like a lecture schedule from the beginning of the year to the end of the year.
that's great.
So at least gradually, I didn't know I was learning anything, but gradually I began to know things. When I came, I knew next to nothing. Nothing. But it's still good you read. If you don't read, but how wonderful the lecturers are, you will be bamboozled. Now, they will not calm down to explain all these things in detail. All this Cowden syndrome, they would have bypassed it since. You have mentioned Cowden and they are gone. So you are saying you don't know what Cowden is your own cup of coffee. So
Let's continue.
Cowden syndrome is also known as multiple hematoma syndrome. It's a rare autosomal disorder characterized by multiple hematomas and an increased risk of various malignancies. It's most well characterized phenotype within the P10 hematoma tumor syndrome. Mm.
Multiple syndrome.
The P10 means what? Sorry. The germline mutation in P10 tumor suppressor gene located on chromosome 10 Q33.23 Q23.3. So the mutation is a mutation in Q10. 80% of individuals have germline mutations in P10, autosomal dominance, and age-related penetrance. So the higher the age, the higher the chance of penetrance. So they have three main things. Clinical features so have the mucocutaneous lesions, neurological manifestations, and GI tract. Mucocutaneous lesions occur in the third decade of life. Tracheostomas, they are benign hair tumors, typically on the face. Do you know how tracheostomas appear? I won't show you now. Oral papillomas on the lips, buccal mucosa, acral keratosis on the palms and so. Facial papules around the nose and mouth. Neurologic manifestations, macrocephaly, Leynet, Douglas disease, polyposis of the GIT, hematomatous polyposis of the GIT, including the stomach, small intestine, colon, esophageal glycogenic acanthosis, multiple glycogen-rich epithelial lesions in the esophagus. Cancer risk, 85% risk of breast cancer. They say 50% risk. 35 to 50% risk of breast cancer. Thyroid cancer, 35%. Endometrial cancer, 28%. Renal cancer, colorectal cancer. Tracheostomas is what you will see mainly. GI polyps, hematomatous polyps, and thyroid lesion, follicular adenoma. So tracheostomas, that's why tracheloma is a very common thing in the exams. You know how it looks like?
Yeah, lobular pleuroplasty, nucleus with peripheral pellicity.
Hmm? Tracheloma, let's see.
Almost like maybe benign form of basal cell. I don't know.
I was done this thing so many times, I keep forgetting. I will taught us in the lecture many times. Let me see. Let me see. Let's see if we can get a handle of it.
Let's take a look at the side.
Let me see this.
Yes, yes.
Yeah, silver polarity, famous small, I don't know. Let me see. Look,
Mhm.
excuse me. So lobular architecture. What's compared lobular related tumors? clear cell, they have clear cell differentiation, big glycogen-rich areas. They have peripheral palisading, and thickened basement membrane, stromal clefting. So I think I understand. I think I'm trying to remember now.
That's why I said the nine form of basal cell. It's just that the cells are different.
Clear cell, yes. Wow.
Peripheral plasminogen, stromal clefting. That one is similarity with basal cell.
Yes, I prefer differential diagnosis of usually repeat 10 mutations. So when you see tricholemoma, find out if the patient has dermatomatous polyps. If the patient also has dermatomatous polyps, what does that mean? Look for serous follicular adenoma. If all those are present, then what does that mean? That means you are dealing with what?
Syndrome.
Or you are dealing with P10 dermatomatous neoplasms. Where is it, sir? It's not P10. What were we studying before? P10. It's not P10 we're studying before. You're dealing with P10 what they call P10 mutation. Cowden syndrome. Okay. So what are the Cowden syndrome triad? Histopathology, things you will see in Cowden syndrome to make you know you are thinking of Cowden syndrome. Of course, tracheostomas, GI polyps, and thyroid follicular lesions. Okay. Okay, let's come back. So Cowden syndrome is, so let's look at the picture. Let me quickly look at this and then we are done. Cowden syndrome. I think these are the tracheostomas or something. I can't remember. Let me see. Skin condition. These are the hematomatous polyps. What kind of hematomatous polyps are these? Is it GCSSP? Ah,
What is GSSSP?
globular cell rich hyperplastic polyps. If today's lecture, that guy would have dealt with all these things. Unfortunately, I'm not there. I don't want to join on Zoom. I have a lecture here. So these are hematomatous polyps. No, this one is your intestinal tract. Let me see. P10 loss. Usually P10 will be lost, right? That's the way the IHC will show. We show loss of P10. Okay.
Which one?
For P10 now. So if you're doing IHC, it's not as if you're going to see IHC P10 present. It should be lost. Loss of P10 is what will lead to all these problems. Okay, so I think it's P10 loss. So breast cancers in Cowden patients are usually ductal carcinoma, similar to sporadic cancers. They have mucocutaneous hematomas, tracheostomas, and papillomatous papules. So follicular thyroid, endometrial cancer. So Cowden syndrome is associated with P10. STK11 is associated with what?
You said
Buschke syndrome and also breast cancer. Buschke syndrome, what are the features of Buschke syndrome? What of inheritance? Autosomal dominant.
autosomal dominant. It's just a cutaneous pigmented macules.
Yeah, mucocutaneous pigmentomatous on the lips and buccal mucosa and GI hematomatous polyps. Well, you understand? Increase of of colon cancer, small intestine, gynecologic cancers, and rest. Usually, but also bilateral and at younger ages. Occur in younger ages and bilateral, the breast cancer. Goiberlinda syndrome is pheochromocytoma, central nervous system angioblastoma, clear cell renal carcinoma, and the rest. And they are not, it's autosomal dominant. It's involved in hypoxia signaling. So let's quickly answer questions and then we are done with this session. I think we are almost done. You see, we have gone beyond half of this. Consistency is actually important. Assuming we think we did a lot yesterday, we would have gone far by now.
How
Sometimes
many questions? How many questions?
Well,
How many questions have you done?
we are number 37. This is 37.
No, this is not breast. Oh. You are looking at something else.
Oh.
You are 20 something.
Ah, anyway, almost half. More questions would have been half.
Which one were you doing on your own? Like you have not beyond half.
I'm doing what's it called?
Soft tissue.
Bone. After bone, I'll do soft tissue.
Oh,
Um,
they did do the bone and soft tissue together.
yes,
They separated it. Ah,
they separated it. So let's look at this. Which of the following gene is not associated with risk of breast cancer? VHL. Which syndrome is caused by mutation in TP53, leaf-from-any? Which gene is mutated in Cowden syndrome, a condition associated with breast cancer risk? Which syndrome is that?
10,
P10. What's the risk of breast cancer in P10?
30%.
Well, 25 to 50% is here. What is the triad of Cowden syndrome?
Things like they for skin lesions like
Papilloma,
uh, follicular syndrome.
of the side of the thyroid, and hematomatous polyps. Creutzfeldt syndrome, which increases breast risk by mutation in which gene?
SCK11.
11. What are the features of Creutzfeldt syndrome? Cutaneous.
Diapause, nicotine, pigmentation, increase breast cancer risk.
Mhm. Which gene is involved in familial diffuse gastric cancer and increases the risk of lobular breast carcinoma?
CD81,
Yeah, those are actually with
loss of e-cartridge,
carcinoma because of decay category, code for E category. What's the lifetime risk of breast cancer in BRCA1 and BRCA2 mutation carriers?
80% lifetime.
How do you read?
Lifetime risk.
What's the best way to reduce that?
Hmm?
How can you reduce the risk if you don't do surgery?
Okay, bilateral profilar
If you don't want to do,
mastectomy.
if you don't want to do surgery, what's the best way to reduce it? Tamoxifen.
Amoxicillin,
Yes. BRCA is located in which chromosome?
17 to 20.
One. BRCA1 is 17q21. BRCA2 is 13q12.3. 17q21, 13q12.3. Which gene mutation is associated with an increased risk of bilateral and multifocal breast cancers?
BRCA
Yeah.
2,
Multifocal and bilateral and multifocal breast cancers. P10. Cowden syndrome. Increased risk of bilateral and multifocal breast cancers. Let me see.
okay.
Let me see. Breast cancer. It's multifocal and bilateral breast cancer, but it's not, you didn't see it here earlier. Which of the following is not high penetrance breast cancer susceptibility gene? VHL. What of the following is a moderate penetrance breast cancer susceptibility gene? ATM. That's what I didn't mention it. So all those other ones like ATM, check 2, those are not high penetrance now breast cancer. ATM, check 2, BRIP1, PAL B2, moderate penetrance gene. So you can memorize these ones. ATM, check 2, BRIP1, BRIP P1, PAL 2, BRIP P1, PAL 2, BRIP P1, PAL 2, BRIP B1, BRIP P1, BRIP 1, BRIP 1, PAL 2, BRIP 1, PAL 2, and ATM and check 2. Which protein is encoded by the CDH gene?
Which proteins of e-cartridge?
Cadherin. Which best describe the cancer risk in women with Creutzfeldt syndrome?
Yes, Okay. Breast and GI,
Breast and GI cancers. Very good.
SDT alone.
What proportion of familial breast cancer risk is accounted for by BRCA1/2 mutation?
So 16%.
Yeah, familial breast cancer risk. Also, 60% is accounted for by breast density too. Breast density accounts for 16% of tumors. BRCA1 mutation, 16% of family for familiar of the familiar one, familiar breast cancer risk. Which syndrome is associated with a germline mutation in tumor suppressor gene and carries the risk of brain tumor, sarcoma, and breast cancer?
Sorry, which question?
14.
Which students need term limitation distribution? Syndrome?
Many syndrome, that's P53. Brain tumor, sarcomas, adrenocortical carcinoma. Finally, which of the following is true about P10 mutations? A. Abi. So, sorry, they call it Countess syndrome to provide the 50% risk of breast cancer. Okay. Yes. Did you see that?
Yeah.
Okay, so that brings us to the end. So next time, what are we meeting again?
And let's target 1:30. You can see me today, I mean, early tomorrow morning for mine. Like
1:30,
the time we meet yesterday, I mean.
1:30 a.m. That will be my 8:30 p.m. Okay, let's see how it goes.
Yeah, that's
Okay, thank you, sir.
you're welcome. Because your wife. Yeah.
That's your family too. Okay, bye, sir.